but this year we are fortunate with that. And as I arrived this morning, I realised that the last leap year we had, which was pre-COVID, February 29th, 2020, we were in Oris Nucteron. So I think that we probably have a bit of a pattern here about hanging around Phoenix Park for leap years. And I hope that we will be able to do it again in 4 years' time. I'm not sure maybe the American ambassador will open his doors for us, or her doors for us, or something along those lines. Anyway, a couple of housekeeping rules. Exit doors, please keep them free, don't clutter them up. There is a bathroom at the very far end of the corridor. When you came in, you would have turned to the left. There's a cloakroom just the other side of the main hall, the stairs as well. So please feel free to leave your coats and stuff there. There are also bathrooms off this conservatory area here. There's clearly rules around what surfaces you can put things on, so just be wary. This is an old building, old furniture, and we need to be respectful of it, that when we ask to come back again, we're allowed. The other point to note is that food and drink in the conservatory area only, please. Don't bring anything in here. So, down to the business of the day. I guess I do feel that things are moving forward. There is more awareness and understanding of rare diseases. We're not there yet, but there is definitely a critical mass approaching, and I think that we're on the up. I feel that we've done a lot of the heavy lifting. There's lots more to do, but there is momentum there. There's people behind us. There's a willingness to engage and to move things along for this community. And I think that everybody in this room is part of that. And we'll also, we all need to, I guess, work together to make this happen for us. I would speak very much from the South. This is a joint North-South event, and we do them every year together. But from the perspective of the South, we are now finally at the stage of developing a new national strategy, really engaging with patients and families to understand what's going on, what needs to happen. I think that our third session of the day around integrated care will be the bulk of what will happen in the next couple of years, that we really need to make a very, very concerted effort to move the dial. And that, that doesn't take massive capital investment. It doesn't take massive magical science. It takes communication. It takes the people in this room and your colleagues back in your offices, back in the hospitals, back in the clinics, back in the community, everybody talking and working together. And I think it's not beyond the wit of man that we can actually do something here. There will be challenges. That's the human condition. People don't necessarily like change, but I think that it is definitely something that we can deliver. The other main areas that will be part of today, we always talk about the diagnostic odyssey, how long it takes to actually get a diagnosis. Sometimes you can be lucky and you'll be, caught at newborn screening, or you'll meet a consultant, or you'll meet a GP who's seen something before and can say, I think it's this, and you'll be, relatively quickly. But for most people, it's several years, 5 years, 6 years on average in Ireland to get a diagnosis. We wouldn't accept it in any other path of medicine. We are lucky enough to have a spokesperson, the global head of patient advocacy from Illumina here. And for those who don't know, Illumina is one of the big companies, dare I say it, that industry is in the room, which I'm delighted with. But they are one of those companies that are looking to that 5-10 year horizon. They're thinking about what do we need to be doing now to enable technologies and stuff of the future. We all know about AI. Artificial intelligence, facial recognition, all of these technologies, they're coming at us. They will happen. And how can we use them to enable that diagnostic odyssey to be vastly shortened? And that's one thing that we really need to do. The other piece then of today's discussions will be around advanced therapies, gene therapies, curative therapies, and what's coming down the pipeline. We're lucky enough to have Emer Cook coming along, who is the director of the European Medicines Agency. We're talking we've gone right to the very top to say, what's happening, what's going to come at us over the next 10 years. And, I hope today's discussion will allow us to understand what do we as a healthcare service, as a healthcare system, need to do to enable these products to be delivered to people on the ground in Ireland. The conversation is not going to be about pricing. It's just, that's another day's work. The conversation needs to be about how do we make it happen? What systems do we need to put in place? Is there any type of governance systems that we need to ensure that patients can get access, no matter what part of the country you're living in, that you can be brought to the specialist centre to get that gene therapy and then go back home? We need to work out how do we do that and what makes sense for us as a country. We're a small country, we can't do everything here, but we need to have adult conversations around what we can do, what we can't do, and how we, for those things that we can't do, where will we deliver those other therapies maybe? Who do we need to link in with? So these, I guess I'm trying to say, we have a strategy in development. It is going to be looking at the next handful of years, 3, 4, 5 years. I'm not sure we've actually set on an absolute timeline. But but we also need to start thinking today about what do we need to do to enable 10 years' time. What needs to happen? And I really do hope that everybody here will engage with that kind of thought process. We're not here to criticise or to challenge or to make people uncomfortable. Let's I guess, in the spirit of unity and working together, let's keep the conversations civil, be kind to one another, and enjoy the experience. That's critically important. Our own Minister, Stephen Donnelly, will be along at lunchtime. The new minister the new old minister from Northern Ireland, Robin Swan, was unfortunately not able to make it along today. I think there are, similar to the challenges we have here, there are challenges in Northern Ireland as well around the healthcare service. But he has sent a little video along, and so I will ask that we just show the video. Very nice, good opening for us here.
Good morning, everyone, and thank you for the opportunity to voice my support for the rare disease community on the rarest day of the year, the 29th of February. Rare Disease Day is a worldwide celebration of the uniqueness of being rare and a chance to raise that wider awareness amongst the general public, policymakers, politicians and healthcare professionals of what it means to live with a rare condition, the challenges that it can bring and the ways in which we can help. I'm a long-time supporter of the rare diseases community. Many of you will know that in March 2022 I published the Northern Ireland Rare Diseases Action Plan, setting out a series of actions to improve the lives of individuals living with a rare condition. My officials in the Department of Health who have made the journey to join you in person today will update you on the good progress made to date on our action plan. So thanks to the continued hard work and the dedication of our stakeholders and the implementation group members, I'm committed to building on that progress and to ensuring that my department will do what it can to improve the lives of people living with a rare condition. I'm sorry I can't be with you all today in person, but as I'm sure you can guess, my diary has become extremely demanding over the last few weeks. But many thanks again for allowing me to speak briefly today, and best wishes for the remainder of the event.
To the people from Northern Ireland in the room, particularly in the Department of Health, please do pass on our thanks to him, to Robin, for such a nice introduction to the day. So without further ado, I'm going to do my very hardest to keep us running on time. There may be a spanner in the works at lunchtime, I suspect, but anyway. I am going to invite the chair of our first session up. Avril Daly will be familiar to many people. Avril is, I guess, a stalwart of the rare disease community. Avril is Chief Executive at Retina International, President at Eurordis, Board Member at RDI, and I'm sure has a number of other titles as well that I could reel out, but I won't fill up too much of our time. So Avril will chair our first session. I can't even remember what the title of it is, something around policy anyway. But I'm delighted to hand over to Avril now. Thank you very much, Avril.
Perfect. Thank you. Thanks, Vicky. Thank you so much. It's wonderful to be back here in Farmley. Some of you in the room will remember that we kind of kicked all of this off on January 20th, 2011, when we had our first meeting of Europlan, which was the European initiative for countries to talk about what their specific priorities were in the rare disease space. And it was actually a very interesting day because, as it happened, the government collapsed the night before. I'm sure, I'm looking at Derek, you remember this. And we were, we'll push through. But we were lucky that one of the first decisions of the new government in relation to healthcare was to develop basically a working group to look to develop a national plan for rare diseases. And so what started as a slightly scary day led to the development and publication of our first national plan for rare diseases in 2014. And this room also held subsequent meetings to look at how we were progressing. And we did have some very good meetings along those years in relation to clinical trial development as well. So we've happy memories of starting something in this room. And, you know, as we move on to the next phases of the development of these conditions, I think maybe this is a good omen that we're here today. On the LEAP Day, the real Rare Disease Day, 29th of February. So my name is Avril. As Vicky said, I am the CEO of Retina International, a patient-led global umbrella group, and it's great to see our Irish member Fighting Blindness here in the audience today. I'm the voluntary president of Eurordis and on the board of RDI as a patient. I'm a person who lives with an ultra-rare form of rare eye disease. So I always say, please, if you see me, say hello, because I'm probably not going to see you, or so please, I always want to make that point, because sometimes the conditions that we live with as patients are not always visible, and I think that's always important to say. So we know that 36 million people across the EU today live with rare diseases, and in Ireland we also know that 300,000 people will live with a rare disease at some stage in their lives, and most of these conditions just do not have a cure. And this, of course, causes a lot of fear and frustration to finally finish your diagnostic odyssey and learn that there is no treatment, and that's a real reality for people and their families. We know at a national level that resources and expertise to treat these diseases are scarce, and that makes the added value of working at an EU level really critical, particularly for a small country like us. But, you know, we talk a lot about, a lot of the talk can be negative about our healthcare system, but once you get into it, I think a lot of us know that it is absolutely excellent in many ways, and to be able to group all of that expertise into ERNs here has been very, very important, and Eileen Tracy and the group at the National Office for Rare Diseases have been instrumental in ensuring that Ireland is now part of 19 of those European reference networks. That's really, really critical thing for us as a country, and shows that we're raising the bar, we're getting to where we need to be. But society is judged by how we treat those with high unmet needs, and people living with rare diseases live with high unmet medical needs in this country, sometimes ultra-rare diseases that have never been heard. This is the same in the north of Ireland, it's the same in the south of Ireland, and in our countries, nobody in this day and age should be left behind because they have a rare disease that little is known about. All our citizens have the right to diagnosis and care, to access to education, to employment, And that is underpinned by the United Nations resolution, which was unanimously passed in December of 2021, that recognises the rights of people living with rare diseases, and that includes access to a confirmatory diagnosis, to the care that they require, but also more holistically to that education, to that employment, and to avoid all of those extreme out-of-pocket expenses that we as patients really have to manage. And that's a real burden also on this community. So not only, I suppose, do rare diseases affect our health, and that's why we're here today to talk about things from a health perspective, but they do affect every single policy, part of our life. And so the policies that we are developing as we approach new strands of strategies and plans must absolutely encompass that, and how we manage our diseases, how we fight them, and how we fight for our future is really important, and it's great to be able to speak to future policies today. So I would mention the Rare Barometer study from Eurordis. Many of you will have seen that, where it talks about the burden and the disproportionate burden that affects women in this environment, with 64% of women having to make sacrifices to maybe education and employment themselves to take care of children, of siblings, of parents, of spouses. But, it's changing a lot, and I think it's very important that what I'm seeing, certainly from a European level, is much more of the family getting involved and the burden being on them. So that's important to remember. So look, I wanted to mention that because I think it's important to understand that there is a European framework for rare diseases being advocated right now. Out of 27 member states, 22 of them have signed up to develop new plans and strategies, including, thankfully, our own government here in Ireland. And that is something that, as a European organisation that I represent, we're working very hard on. They're over in Strasbourg actually today, talking to our MEPs about all of this work and pushing it forward, because we need a framework. There is a lot of legislative review happening right now in Europe to look at things like health technology assessment, the pharmaceutical legislation, the European health data space, transparency directives, that sharing of data, which is critical for us in rare diseases. We must understand this is all being discussed at the same time. We're entering into a European election in June. We need to keep the momentum moving forward, so when we have new leadership, this remains a public health priority. But the signs are good, the indications are good, the support that we're having at a national level we should be very thankful of. And I'm really looking forward to hearing from Ryan Wilson shortly in relation to what's happening in Northern Ireland. But before we do, and before we get on to our panel, I'd like to introduce Cecily Kelleher, who is going to speak to us about her role as chair of the plan for the next rare disease, the rare disease plan and strategy in Ireland. So I'll hand over to you, Cecily, to update us on what's happening, and we can discuss that further on our panel. So thank you very much.
Thank you very much indeed, Avril, and good morning, everyone. I'm Cecily Kelleher, and it's been my privilege to be appointed to chair the National Rare Disease Steering Group by the Chief Medical Officer, Breda Smith, and the Minister for Health, Simon Donnelly. And my background is in public health medicine, cardiovascular epidemiology. I've worked for many years in non-communicable disease, in disease surveillance, and also in health promotion. And so I haven't been directly engaged with the National Rare Disease work previously, but I was tremendously privileged and intrigued to be asked to facilitate as a chair this tremendously important work. And so I'm delighted to be here this morning. I thank Vicky McGrath, of Rare Diseases Ireland for this invitation, and she set out for you the challenges that face us in this space. And also, Avril, it's been my privilege to meet you and to be associated with the work you're doing, and you've just outlined for us what needs to be done at a European level. So today we're talking about driving change through rare disease policy. And what I hope to do is give you some background to this. If I can change the slides. And just to set out, we started this work in December, and from the get-go, there's been huge and positive engagement with this work. We had our first meeting on the 7th of December, and our task is to develop a national rare disease strategy with an associated action plan. There are 15 members at this point on the group, and it is very much a focused interdisciplinary group with patient representatives, with advocacy groups, clinicians and clinician scientists, membership from the Department of Health, from the HSE, and from the Health Research Board. And just to briefly introduce our group membership, Eileen Tracy as the clinical lead for the National Rare Disease Office, Abby Collins from Public Health Medicine for Children in the HSE, Atifa Wan, who's a clinical representative for the Pediatric ERN, Cormac McCarthy, who's a clinical rep for the Adult European Reference Network similarly, Mark Bale, who's the national lead for genetics and genomics, Una Ward from the Health Research Board, Derek Mitchell, co-chair of IPOSI and our Patient Forum, Vicky McGrath, also a co-chair of our Patient Forum from RDI, Ciara Martin from HSE Integrated Care, Dervla Gray from HSE Integrated Care, Kieran Murphy, Rare Disease Policy from the Department of Health, Rosie Gowan for Clinical Lead for the National Clinical Programme for People with Disability, a nominee from the ICGP, and also delighted that Alan Finglas and Gillian Stafford were able to join us as patient representatives. So you'll see this is a strong group at a very key time. And one of the key pieces for me is not just that these developments are happening at a European level, but we are at a point of major development here in the Republic of Ireland in terms of the rollout of Sláinte Care. And a key to this will be local, regional, and national action. A thing that attracted me most to this is that patient involvement is key to this. We have 2 patient representatives and advocacy group representatives on that group, but we also have an underpinning rare disease forum, which met for the first time on the 14th of February, co-chaired by Derek and Vicky. And to me, that lived experience is going to be crucial to the policy that we develop. We have to ensure that the rare lived experience of living with the disease and families remains a focal point for the new strategy. One of the key occasions in recent weeks was the IM17, and this very much reflects what we must do here. We must move that odyssey into a journey that is manageable, real, effective, and I see this as a key underpin of the strategy. The steering group terms of references are available online, but clearly we need to consider how best to improve that access, to ensure appropriate access for people living with a rare disease and integrated care. And that will be a key part of this forum today. We will have consideration for those European developments, particularly the ERNs, but we need that robust consultation process. And that has been underpinning since we started this work and will right through to the recommendations of our policy. Feedback around the quality of registry frameworks is a very important component of this, as is promoting rare disease awareness and participation in national and international research. I'm also very cognizant, as you will be, that if we arrive at a strategy, we must have a means of implementing it. It must fit in to the governance that is developing in our healthcare system here in the Republic, into the international framework, and there must be a clear funding implementation plan to roll out of that work. So very much it is on a timeline, but to deliver. The themes for consideration and the way we are working in relation to this will be very familiar to people in this room. Patient engagement and empowerment at all parts of this, not just in the consultation, but in what we actually roll out, will be crucial. The work in relation to genetics and genomics will inform very much what we are hoping to achieve as well. And of course, therapeutic care will be a key part of this, as will research and clinical trials. We must learn from our European experience, engage with it and deliver upon it. We are already getting very significant feedback in relation to the protocols for newborn screening, for data registries and for care pathways. So the plan will be comprehensive. The work to date has moved along apace, even in the last few months, and we have a very tight work programme that will roll through to the middle of this year. I've already shared with you briefly the terms of reference and the work plan to be developed. We very much are working to moving on from the last National Rare Disease Plan in 2014 and to the future. And to Vicky's point, we believe it will be at least a 5-year plan. But this is a very rapid-moving, scientific, social, and community, political sphere in which we're operating. So we have to really capture all of that and align with the EU's rare disease framework. One of the first documents that was commissioned and produced and is already available was published on the 8th of February, was a piece of work undertaken by HICWA, which was to review rare disease developments in selected countries. And that work was ably done, presented to us in the working group and published, as I say. 12 selected countries were reviewed in that, including England, Northern Ireland, Scotland, Wales, and selected European countries, as well as Australia. And that looked at a systematic online search for national strategy documents and, as relevant, key interviews from each country to confirm relevant resources. Those strategy documents identified for all 12 selected countries looked at the main strategies and action plans. They looked at the evaluation of recommendation documents in 7 of those countries and also supporting documents. So it was a very thorough initial piece of work. Our next steps as we go forward in relation to this is to work with the Patient Forum, which will continue to meet and which I hope you will engage with to inform very much the work of the steering group. We also plan a wider consultation, a public consultation, to ensure that all stakeholders can input into this new strategy. I have had so many people contact me since I started this work in December, and I'm very hopeful that we will get the level of engagement in that consultation that will truly inform the work of this policy. We've already had quite an approach to a focused steering group process, and we'll be meeting very regularly, more frequently than monthly at the moment, with aims to produce the new strategy. And I am very clear that we will develop an implementation plan, an oversight group that will ensure this new strategy is fully implemented. So it's a pleasure to be here this morning, a pleasure to participate in the meeting. And I thank you for listening to my brief summary, and I suggest that it's time now to leap ahead. Thank you very much.
Thank you very much, Cecily, for that overview, and we look forward to discussing and getting into this at our panel. I'd now like to welcome Ryan Wilson to the stage. Thank you, Ryan. Good to meet you. Ryan is Director of Secondary Care, Northern Ireland Department of Health, and he's the Chair of the Northern Ireland Rare Disease Implementation Group. And so I think you're going to speak to us today about what's happening in Northern Ireland, and I think it's really important for us to have that perspective of what's going on the island, and we can learn more about your work. So thank you for joining us this morning.
Thank you very much, Avril. Can you hear me okay, folks? Good morning, everyone. As Avril has introduced me, I'm Ryan Wilson. That's me from the Department of Health in Northern Ireland. I'm the Director of Secondary Care, which is a policy team looking after many hospital services, but one of my roles in the department is as Deputy Chair of our Northern Ireland Rare Diseases Implementation Group. So I'm going to talk a little bit about our policy work and how that is hopefully relatable to actual change and service delivery on the ground. But I also want to say all of the hard work, and that is not done by me, it's done by my colleagues, Finola, Anthony and Scott, who are here with me today. So I hope we get a chance to speak and meet with you during the day. So thanks also to Vicky and colleagues for the invitation to attend this event today and the very warm welcome. I've been at some of these events over the years in Belfast and Dublin in a couple of really brilliant venues and really good events. And I suppose congratulations for keeping that momentum going even during the COVID years in some shape or form, and to keep the communication going between our two systems. But it's really good to be back in person and to have the opportunity to speak with you all today. So, firstly, just to speak a little bit about the strategic background. You just heard from our new old health minister, as Vicky referred to him, Robin Swan, who has just come back into post in the last 3 or 4 weeks as our health minister. For us as officials, that's really beneficial because Robin was there. He was the minister who launched our current action plan back in 2022 and had signed up to our strategic commitments under the UK Rare Disease Framework. So it's really helpful to us as officials to have a minister who knows the crack and the background to this and has previously sort of stated his commitment to progressing our work on rare diseases. As he said in his video, he has been a great supporter of this work in the past. Many of you know that the rare disease framework that I referred to, the UK Rare Disease Framework, was jointly published by the 4 UK health ministers in January 2021. Obviously, we were in mid-COVID response at the time, but we tried as best we could to keep some of our normal policy work with some momentum during those times. The framework outlines the UK's priorities for rare diseases over a 5-year period, and sets out a framework for each of the nations then to develop its own individual action plan, which is specific to the priorities within each region and the needs of the population. And we work together through the Rare Disease Framework Board to ensure that those respective actions are aligned under the terms of the framework. So the next slide here, you can see the photograph which was marking the launch of our action plan by the Minister in 2022, here with the then Chair of the Northern Ireland Rare Diseases Partnership and our Chief Scientific Advisor Ian Young, who chairs our implementation group. Unfortunately, Ian is unable to be with us today because he's in New York and sends his apologies. So the implementation group, or NERDIG as we refer to it in short, brings together all of our stakeholders from across the policy areas within our department, our 5 health and social care trusts, our commissioning public health partners, research and development leads, academia from the 2 main universities in Northern Ireland, and the Rare Disease Partnership. It's similar, I think, to the steering group that was recently been established here, as referred to by Cecily. And during 2021, our implementation group worked with all the stakeholders to develop our action plan for Northern Ireland and consult with the rare disease community to inform the work that the partnership had done previously and identify the priorities that we could realistically try to take forward over the next few years. So I just want to give you an overview of the working groups that exist under our overall implementation group, or NERDIG. We've agreed to 14 high-level actions with an overall vision to improve the lives of people who live with a rare condition in Northern Ireland and their families. We have established or grouped those 14 actions into 4 working groups who are responsible for taking those actions forward. And the working groups are led by members of the implementation group and have representation from our Northern Ireland Rare Diseases Partnership, as well as clinicians, academics, commissioners and research and policy leads from across our health and social care system. Those groups have been working really hard over the last couple of years, despite many financial and resource challenges and many busy day jobs on top of that to take forward the action. So there's really fueled on a lot of goodwill to try and take forward collectively. I mean, I've seen as deputy chair of the group a real will to do what we can within very limited and challenging circumstances to try and keep some momentum. And I'm going to just speak a little bit about what has been progressed over the last couple of years. We meet as a group every 3 months to just hear updates from each of the working groups and try to keep that momentum going. We published during 2023 a Year 1 progress report, and that's available on our departmental website. And at the minute we're just working on our Year 2 progress report, which will build on that. As I said, despite a very challenging financial climate, and we as you know, have been operating without an assembly, without fixed budgets for several years. We still don't know our budget for the next financial year. So that's the kind of context within which all of our policy development is taken forward. But despite that, our work on the action plan to date has managed to make very good progress. And there's a lot that I think we can be proud of. And referring back to your newly established steering group, I think it would be there's opportunity there for us to maybe build more communication and maybe learn from each other as we do that, because I'm sure that the same challenges will exist for yourselves. That is down to the hard work and the commitment and the focused determination of the NERDIG members, and by extension the other stakeholders who they represent and their respective organisations. Many hours of time on top of their busy workloads to keep those actions driving forward. I hope some of those members have made it down on time. I know Patrick, I did see Alison and Laura, but hopefully other folks from the Rare Diseases Partnership are here today as well. So today is an opportunity for me to place on record again our thanks to all the members and the working group leads for what they've achieved so far in rare diseases. And we're very grateful for their continued support and their efforts. So, just to mention what's on the slide, those are our 5 sort of key working groups. Group 1 looking at the development of a rare diseases expert centre, the establishment of a patient portal and information hub. Group 2 is looking at the development of registries, pathways, specialist drugs and treatments. Group 3 is looking at education and training. Group 4 is tasked with research on rare diseases. And in Group 5, we're scoping the possibilities or the different options for having a rare diseases champion for Northern Ireland. And a lot of that is developmental scoping work. Some of those actions will require funding or recurrent investment to take forward, but what we've been able to take forward a lot of the scoping and exploratory groundwork to hopefully build on that when we do have a bit more budgetary certainty, hopefully in the future. So progress to date, we're now approaching the end of our second year of the 5-year action plan. And this is just to give a brief overview of some of the progress since that was published in 2022. In year one, our focus, as I said, was groundwork for future years, scoping, developing what the costings or the investment requirements may be for a rare disease registry, reviewing our rare disease coding infrastructure to inform the registry. We've drafted an options paper looking at the potential for the rare disease champion, as mentioned, and a task and finish group which is developing guiding principles for our healthcare professionals when transitioning a child with a rare condition into adult services. There's extensive work ongoing, as I said, within the research group and applying for funding across various external sources, and there's been some success on that front, which has helped to move the agenda forward as well. We've also tried to move the agenda forward by linking with other strategies that have been published by our department and by the UK government, which we're a part of. That includes Genome UK, our Northern Ireland Mental Health Strategy, and our Encompass programme, which you may have heard of. That is our major flagship digital infrastructure programme, which is currently in the process of introducing a digital electronic healthcare record in Northern Ireland, and we've spoken about this with the rare disease community over years. It's now actually come into fruition, and we've always thought that rare disease community is one of the groups that's most likely to see benefit from that development. So it's in the early stages of actual rollout across our trusts. There will be more development to come, but I think that's an exciting development, particularly for the rare disease patients and their families. During the period in recent years when the Assembly was suspended, there was an all-party group for rare diseases established, and that's continued to meet despite the Assembly being in a pause for a couple of years. So we've had the chance to engage with our all-party group as well, and that contains members from across the main political parties, stakeholder groups, who have come together to look at overall rare diseases and a couple of deep dives into specific issues. So we hope to have a constructive relationship with that group as well. It's really helped to bring rare diseases to the forefront in terms of the political stage. And another really significant development for us in Northern Ireland has been the appointment of both an adult and a paediatric rare disease consultant in our health and social care system. Those are, I'm going to name them, Alison Muir and Patricia O'Hare, respectively, and they provide clinical leadership within the Belfast Trust and across the region, with the aim of driving forward the coordination of care for conditions such as inherited metabolic disorders and inherited cardiac conditions. So moving on to year 2 progress. As we got into year 2, as I said, there had been good progress made to sort of set the foundation. We managed to secure a small amount of non-recurrent funding to help implement the action plan, and we've been determined to try and make that count. That funding has been used to provide much needed resource support to the working group leads, the 5 groups that I mentioned under our implementation group. And it has funded additional genome sequencing of rare disease patients within our regional molecular diagnostics service in the Belfast Trust. And that helps to provide a diagnosis faster than otherwise would have been possible. The funding's also contributed to a patient and carer survey, which is going live, I believe, this week, and to gather the experiences from rare disease research participants in Northern Ireland. And that will identify challenges that currently exist and how we may overcome them. Some of that funding also has gone to our friends in the Northern Ireland Rare Disease Partnership, and that will help to support further engagement across the rare disease community and gather some feedback on the action plan to date. So it's really important that we have an opportunity to do that engagement across the region. Some funding was also put towards the development of an online database of education and rare disease resources for students in the Ulster University. to complement the newly formed Rare Disease Society in the university, and it will help raise awareness of rare diseases right across UU, help to unite the students, encourage advocacy, and foster a deeper understanding of rare conditions which are prevalent in Northern Ireland and beyond. In year 2 of our action plan, there's also been, as I mentioned, a number of research bids that have been successful and are coming to fruition. That has been funding for the development of an online support tool for carers of people who live with a rare disease, called Caring with Rare, and a rare disease NI webpage, which is currently in phase 1 of the Northern Ireland Information Hub. So both of those are in progress, under construction, and not yet live, but hopefully will be soon. We've also seen the creation of specialist service manager posts to support the rare disease clinical leads that I mentioned in adult and children's services, and that will help to support care pathways and ensure better clinical support for the rare disease agenda. So I want to also, while I'm here, congratulate Laura Cassidy, who is with us, and Patricia McGuinness on their recent appointments to those important roles. So there's a lot happening across year 1 and 2. That's a flavour of some of the work that's been done, as I said, on limited investment, but I think it exemplifies just what can be done if you gather people together in a room or virtually and ask them to work together. I'll finish just by speaking about our plans going into 24-25. As I said, we have the return of some form of political normality in our assembly. We hope that will open up some opportunities for us with the profile that the all-party group has brought. There are wider developments taking place in genomics, in the Encompass programme, and in research through clinical trials, and the ongoing work of our rare disease clinical leads. All of this will contribute to the further progress with our 5-year action plan. And we hope to explore further cross-border opportunities, whether that is in the areas of specialist care, genomics, or clinical trials, whatever ways we can to help improve the lives of people who live with a rare condition across the island. And the All-Ireland Rare Diseases Interdisciplinary Research Network, or RAIN, I think is a prime example of the power of cross-border working. We'll also continue to work very closely with our UK counterparts, as we do through the Rare Disease Framework Board, and learning from each other, sharing expertise and experiences, and combining our efforts where it's possible to help influence strategy and policy. I think if we've learned anything over the last 2 years and the years that preceded that, it is that working together makes us stronger and can lead to progress in difficult circumstances. More funding would be nice, and as I said, will be necessary for some of the big objectives within our action plan, and we know that. And hopefully in year 3 we will be able to secure further funds towards the Rare Diseases Registry and the Information Hub. But our implementation group and its component members and organisations, I think, can be extremely proud of the progress that we've been able to make, particularly over the last 2 years, in sowing the seeds for the future work. Again, like your steering group previously mentioned, it would be remiss of me to finish without stating the vital importance of the lived experience role in all of this work, and our action plan would really be meaningless if we didn't have input and regular engagement from the rare disease community. So I want to thank the Rare Disease Partnership once again for working with us closely and facilitating that patient voice in policy development and implementation. I'll finish by saying that myself and colleagues in the department and our Minister are committed to further progress with our action plan. We'll continue to play our part to raise awareness of rare diseases on the political stage, and in terms of our strategies and policies, and to push for resources as much as we can to continue to deliver on our action plans and our strategic commitments. I think it's important we collectively do whatever it takes to put anyone who's living with a rare condition and their families at the heart of health and social care across Ireland. So I will finish there, and thank you all very much.
Thank you. Thank you, Ryan. Thank you so much for that very comprehensive presentation, as I certainly have a lot of questions and I know we have limited time, so I might just ask our panellists, Cecily, Ryan, Derek Mitchell and Gillian Stafford, to join me here for the panel discussion. Thank you very much. Just take your seats. So I might just start with you, Cecily. You're right next to me. So, you know, it was really great to hear that the plan is ongoing, and I think the engagement from other stakeholders is really critical, and the structure of that happening parallel is very encouraging, I think, to a lot of us who are patient representatives in the room. But I suppose the question that always is asked really boils down to timelines and implementation at the end of the day. So I just have a quick question, like the timeline for this, and then looking at that implementation piece, what are we looking at from that perspective?
So we are on an ambitious, but I believe achievable timeline. So this work got up and running, and at the end of December, by mid-year, I would hope we would have completed most of the consultation components, and the plan should be well and trained to be drafted and completed. So I would say our ambition is to have a plan rolled out comfortably in 2024.
Great, that's encouraging, and I think, Ryan, one of the points that you raised was engagement cross-border. There are a number of areas, I suppose, that we would be familiar with here in the South with respect to the work that going on, particularly genes and genomics. You know, the possibility of working more collaboratively. I mean, from the fact that we're in this development phase, is that something that you think would be priority for us and something that we should focus on?
Yeah, I mean, I think it's possible, and it's been a long-standing commitment from our minister and previous ministers within the UK framework and the previous UK strategy. There's always been a recognition that in Northern Ireland we have obviously an opportunity to collaborate more closely with neighbours in the south, and that makes a lot of sense. I think, I mean, I've been involved previously in establishing the Congenital Heart Disease Network, which is a different type of service, but I think it has proved the potential of working together where it's feasible and where there's benefit. I think on a practical level, in terms of establishing the steering group, policy officials, and at that level, there's definitely potential in learning, and we're very happy to work together. Also on the clinical level, and in terms of the engagement with the public, there is potential there. It's we have challenges in that, and protecting enough time within our department and resources to do it, but certainly there's political commitment to that and cover, which I think we can build on wherever it's feasible and where there's an appetite to do it.
Yeah, that's something I think we've discussed before, and I think last year in Belfast, it was when we were in Stormont, that was one of the key areas that we were discussing. And Derek, I'm looking at you. Derek is the CEO of the Irish Platform for Patients' Organisation, Science and Industry. Not your first rodeo when it comes to rare disease national plans. I know that you were involved in the development of the plan that was produced in 2014, and are, of course, engaging in the committee here in Dublin under Cecily's chairmanship, which is fantastic, by the way, and we must compliment you on the work that you're doing. So, looking at it from being through it before, is there something that you would say the pitfalls that we need to avoid, and potentially what we can achieve this time round. Exciting to hear about the various forums and consultations that are happening here, which, so maybe you could just elaborate a little bit on those.
Thanks, Avril. And I guess for those of us in the room or online who are that long in the tooth, I guess for me, I would probably ask the question, well, the question that invariably comes to me about national development of national policy is, so what? For both patient groups, individual advocates, but also the what you might call the health interested public, which IPOSI now has, I guess, the reach to our citizens' juries. And the other kind of question that says, in terms of what's different this time. And I think for me, what's different this time is there's two key elements that weren't in place when the last plan was developed. And as you're well aware, the last plan was developed as a result of what you might call pressure coming down from Europe. Whereas this time, the pressure is coming from within. And that's very different if you think about the willingness to engage with the very complex cases that often come through from the rare diseases, the diversity of voices that often are there, and how you bring that into a coherent plan that can implement. So if the motivation is coming from within, and when I say within, I mean from within the Department of Health, there is a very strong, dedicated team in the CMO office that's helping facilitate the development of the plan, but has that expertise in both policy and implementation. So that was not there before. We have a number of members of HSC, the key HSC departments and roles, and as Cecily mentioned earlier, the way in which the HSC is restructuring around Sláinte care. Rare diseases has a massive opportunity to be firmly embedded within that new structure. And for me, that's very different from before. Because I think it's fair to say that the previous plan, despite a huge amount of work that went into capturing a very comprehensive plan, it didn't implement as well as it could. So that's what I'm looking forward to ensuring that's different this time around. And another key opportunity is around the way that we structure and collate the lived experience. And again, despite the best efforts of many of the patient groups and advocates of the previous plan, that was not there. Yes. So, and I'm very much looking forward to how we're going to structure the Rare Disease Forum. We've just announced a couple of working groups that we're going to concentrate on the kind of things that maybe Ryan was talking about in terms of those maybe, kind of short-term actions that will produce real benefits and real impact for those living with rare conditions. That's in the coordination of care, the integration, the transitions, and accessing services locally and regionally. Those are the kinds of things that they're really, I don't know if Anne Lawler is here, but the back of the ranch kind of things, right? Yeah. So we're moving on those. But as we're moving, we're actually learning how to structure this because we've had over 100 expressions of interest to that forum. Those of us who are chairing it and the patient reps on the National Steering Committee we take it as a kind of a responsibility to ensure that forum is as impactful as possible, not just in the development of the plan, but the implementation of the plan. And the last opportunity, I think, which is different this time around, is that when you speak about implementation and where it fails or not, you need champions within the public health service and system, the likes of Robin and Ryan, who are always pushing for viewing the legislative, the regulatory issues through a rare disease lens, and bringing that lens constantly to the table in those kind of broader issues and linking with them. And what's different this time around is that from the very strong messages we've had from the CMO's office, and when the next CMO comes into place, We'll certainly be looking for them to come and to really appreciate how rare diseases can be part of their agenda and can have wins for them as they operate in that broader scheme. So again, big opportunity for rare diseases, and that's what maybe I would be responding to Cecily's point about leaping forward. So
Yes.
that's where the leap can come from.
The leap, yeah, exactly, and that's important in understanding that patient engagement piece that you mention, and the fact that you're providing that platform to really discuss real world issues that are really fundamental. And Gillian, as a patient representative on that committee, bringing that lived experience to the table. I mean, one of the recommendations that we've had at a European level when we talk about action plans across the member states is that integration of that lived experience with health. So the integrated health piece, how do you feel as a patient that can be brought forward? Having on the panel, of course, with Alan is critically important, but from your lived experience, is that opportunity there for you to really discuss the day-to-day and the reality?
It's not there day-to-day. It's great that I'm on the steering committee, but what I find is that because our patients with rare diseases, a lot of the consultants and medical people in Ireland don't know about our disease. So a lot of the times we're in and we're fighting for ourselves as patients, so it can get tiring. So I think there needs to be more education around how people in the medical fields or even in the HSC or different areas can work with patients. Because a lot of the times you're going in and you're having to describe your illness, and sometimes you get fed up by going in and there's somebody with a medical professional sitting in front of you and they're saying, well, we don't know what this is about, and it feels like I'm fighting all the time. Where being part of the steering group with the patient forum, I feel like my lived experience has been listened to, where in other areas it hasn't been up to this stage.
So you're being listened to.
I'm being listened to, and actually,
Yes.
if I have a point, I'm not afraid to actually say within the steering group or the patient forum, because I know I'm in a safe environment where I could express my opinion and it's being listened to. Where if you're doing it on your own, it's kind of people, you're knocking on doors, but they're saying no to, and you get fed up with doing that on your own. So I think it's a great experience being on the steering group.
And I think that was evident, and I had the pleasure of attending one of those meetings to present, and I can say to those in the room there was a real energy, and everybody had the opportunity to speak. And I think one of the really interesting presentations that I saw on the day, Cecily, was the HICWA report, where HICWA have looked at 12 examples of rare disease implementation across Europe, and I think a little bit beyond. How has that helped you in sort of framing that discussion?
So absolutely. So we have to learn from the experience we've had already. We have to build on important developments like, I would instance, the National Rare Disease Office. I would also think that it is crucial now that we have this rollout of Sláinte Care with all the challenges it has, because that's a real window of opportunity for high-class surveillance, for the establishment of the registry framework, all of those things. But I think Gillian's point about engagement is crucial to all of this. And we have to capture that journey, and we have to translate that journey into a healthcare delivery system that will pick up on that experience, that will know where the pathways are for referral, for care. It is crucial when you step into your GP's surgery at a local level. It will be crucial if you go to your county hospital or some other regional service. It'll be important that we have a national framework that understands protocols of management. So at every level, this is going to be very important. And to the point about the HICWA piece, so we have to learn from what's going on in our own jurisdiction. I think the cross-border dimension, it was really interesting to hear so much that you've already got done, and we really should share that partnership. Wearing another hat as a Dean of the Faculty of Public Health Medicine, we have a lot of cooperation cross-border in that area, so that's another piece to build on. All of our healthcare systems are different in the way they're organised around the European region. We learned a huge amount during the pandemic period in relation to shared data and surveillance, how different healthcare systems are delivered. So that's the whole purpose of the HICWA exercise, to tell us in those 12 different jurisdictions, how did they translate? And this is all about translation and implementation. And so I gave you a timeline shortly ago. We will try to keep to that. But more importantly, we must ensure that there is an actual who, what, how component to the implementation.
Absolutely. I think, Derek, you had something to...
Yeah, I think what struck me about the HICWA review, two things that struck me. One was around a lot of the priorities in other countries are the priorities that have been identified in already. And there was huge consensus that these remain priorities, these remain unmet needs for many patients. The other thing was about the influence of the UN resolution and how that is starting to filter through into the national plans, and how if you take that more universal approach to healthcare, that these areas are now coming into the prioritization process. And it's great to see that coherence between global level, national level, and feeding down hopefully into that regional and local level. The other thing that struck me around what's happening now, and really struck by the examples coming from Northern Ireland in terms of the Encompass initiative and electronic health, and we're finally seeing the building blocks of what would be ultimately the rollout of digital health in Ireland. And I think by the end of next month, you're probably going to see that national framework for digital health, together with an implementation plan, and yes, a price tag associated with what the necessary investment that's going to be needed. But I think if you look at that kind of whole piece about, well, how then do you bring a rare disease lens to that? Yes, we need the ORFA codes. Yes, we need in the clinical systems. Yes, we need the data moving between different silos and sectors. But fundamentally, we need to use that data for secondary purposes, for research, for innovation. And patients and citizens need to be part of that. It's because fundamentally, the data is ours and it is theirs. So that is a wonderful opportunity, again, for rare diseases to bring that lens, because if we think about how we can leap forward in terms of trusted research environments, we can build these things. These are not rocket science. It's been done in Northern Ireland, it's been done in other jurisdictions. There is absolutely no reason why we can't build these. But the real leap forward would be to build it with citizens and patients right at the very heart in terms of the use of the data, for different purposes, whether it's surveillance or whether it's public health purposes, or indeed for those research priorities that people have actually said, this is where our data should be going. So again, really good opportunity.
Thank you, Derek. And I know Vicky will have words with me if I don't open this to the floor. So I think, does anybody have any questions? We just have time for maybe one or two questions. I think there's one here. Yes.
I have more a comment maybe rather than a question, and it refers specifically to what Gillian said. I'm Mary Carney. I've experience in general practice. I've experience as a European reference network, as a patient advocate, and I'm a parent with two children who've got a rare disease. And no general practitioner and no doctor can know absolutely everything about the 5,000 plus rare diseases. So I've been advocating that the patient journeys, which we're doing at the European Reference Network, and the care guidelines that people have for their disease, that the patient should have them and present them. And I know it's an added burden for those with rare diseases, but I can only see that as the way forward, as no person could be expected to know every in-depth detail about every single rare disease.
Mm-hmm. Does anybody want to take that? It's something I think that we've all had challenges with throughout the years. It again goes back to the limited experience. But I think Mary, you've been fairly instrumental in engaging GPs in understanding rare diseases and having some patients speak to them and using that sort of forums for discussion.
Yeah, but I've tried to do that, but it hasn't been very successful. It's very hard to engage general practitioners in rare diseases because they're saying rare diseases, let the hospital look after that. Yeah. That's not, when you have a rare disease that you live your lifetime with, the general practitioner does need to know about it. And I hope in my work that I'm at least receptive, Gillian, if you come to me to say, yes, what do you know, and to listen to what you know. And it's that the general practitioners would at least listen to the patients and acknowledge and know that the patient organisations know so much. So I am trying to do some work around that, but it's really, not easy.
Yeah. I'd just like to say, I think I really welcome that, and I think I've worked in a number of studies that have engaged general practice as part of wider work, looking at patient health records, for instance. I believe it's going to become a much easier proposition to be able to bring data or information with you and to put that over in the consultation that you're having one-to-one. We have placed a strong priority about general practice engagement in the steering group, which we are rolling out. And I think, yes, absolutely. But in a number of the studies I've been involved in over long years, the key component has been to get the GP engaged with the broader delivery system. So it's a very good point to take on board.
Yeah, I completely agree. And I do think that access to your own health record will be part of that conversation, but it's no general surprise to me to see that we still remain with a gap on the National Steering Group from the ICGP, which reflects the challenge of identifying someone who can actually then channel it back.
It's a broader issue than that. It's the person with the rare disease going to casualty, and the casualty doctor doesn't know anything about it. That's where the patient really needs their guidelines, and I see somebody nodding their head here in front of me as well. It's not just the person's GP, it's the whole...
Absolutely.
And nobody can know everything. So that's why the patient needs to take a little bit of ownership and bring their guidelines with them.
Yeah.
And just to build on that, my name's Karen Walker from the Multiple System Atrophy Trust, and we support people across the UK and Ireland. And quite rightly, the GPs, how could they know about MSA? They get one in their full career, to their surgery, perhaps. But one of the things, I've been interested to listen, and I'm very interested, Gillian, in what you had to say, because, obviously the patient voice is one of the things that we're very involved in. But as a result of that, we also have developed information that we can share with GPs and with hospitals. And we've also developed packs such as, I wish I'd known that a year ago. And we've done that for the South, for Ireland, as well as for UK and Scotland. Wales is just completing, Northern Ireland is on its way. So, we do have those things that we can send to people, but it's how we can feed in as well to the development of your plans. That's what I would be very interested to hear more about today.
Great. Good points to take on board, for sure. And we might have time for just one more question before we break.
Hi, Avril. It's back at the ranch, Anne.
There's Anne.
Can I just say a word about that? It's the nature of rare diseases that we as patients or carers become experts. And it's our lived experience and our expertise that can add so much to this. We're very lucky. GPs are our gatekeepers. They really are, and the guidelines are so important. We're very lucky in 22Q that we have international guidelines, and before we secured our clinic, that's what kept us going, because the GP would have those guidelines and would work off them. So it's really important that our expertise, and like most of us, I think any rare disease patient has gone outside of Ireland to find their tribe, as I call them. And there's such a wealth such a wealth of knowledge, insight and experience that we can bring this forward. So I just wanted to say that.
Great.
And thank you, everyone.
Thank you.
Thank you. We have one more question down the back, and then we'll go for...
Barra O'Brien from PSPA Ireland. I just would like to ask the panel, is it possible for consultants and people who diagnose, for them to give information or get their people that are working with them to get information to the patient at the time of being diagnosed? We have found in PSP that it takes approximately a year and a half to get a diagnosis, for example. But at the end of that, you have to go looking yourself all the time. Whereas these people are experts in the disease. But I would love to see doctors giving out, say, I'm just taking for us, we have a backup and an experience in PSP. So therefore, we could help that patient straight away. And I think the more medical people think that way and give us a bit of information to the patient at the time of diagnosis, because their head is up in the air. They're just, they don't know where they are. Thank you.
Yeah.
I don't know if Derek wants to comment.
I can probably comment on the first question, just in terms of the way that certainly I see the Rare Disease Patient Forum being influential and impactful is where patient groups, individual advocates can have their voices heard, but that collectivization can actually happen so that the priority can be clearly articulated to where the need is the greatest for rare diseases. The examples you've identified are perfect examples of that. It's then up to the system then to devise the channels and the ways that this can actually be implemented. So the point about how GPs can access care pathways, guidelines, not just relying on the individual in front of them, but they have an information system that they not only see as part of that consultation, but that they can easily use and the patient can actually feed in as well. So, and that's a very different relationship than maybe what currently exists, which is paper-based. There's very much reliant on the burden. It relies very much on the individual. So that's where I hope that can come out of the forum, because when we look at other areas of where this is actually achievable, the Cancer Control Programme has really tried to do this in a cancer-specific way in terms of survivorship and how that feeds into the national agenda. I would like this to do the same for rare diseases. So that's very much why we need that.
Yes, and just looking here, when I'm looking at you, Derek, I'm seeing over your head driving change through rare disease policy. And I think one of the things that's happening right now with while they're fledgling, and I think it's really important to say that European reference networks, should be better understood by GPs, and specific healthcare practices, because they will become the centres, much better known. They're, what they're doing, what they're for, how to refer patients to them, and in so doing, you're getting access not only at a national level to that expertise, but if your condition is not known within the country, I've got Vicky. It's, we have to, there is opportunity to get broader expertise across Europe. So there are opportunities, but they need to be developed. So there's some infrastructures in place that can support this, but it's early days. And so these are discussions that are really important as as we move forward. So, Vicky, I think that's you doing a dance down at the end.
Sorry, can I comment, please, Eileen?
It's Eileen. Okay, sorry. That's Vicky, but it's Eileen Tracy over here. Okay, sorry, go ahead.
Sorry, I'm not sure the microphone is working, but
yes.
just for on a positive note is that the care pathway and entry to the care pathway from the point of care, which we know for ourselves from review in Ireland is at primary care, is GP level. This is a very central point in the Jardine joint action. Yeah. And so this is signposting from the GP of where the care is in your country and where the care is throughout Europe. And it's also delivering a clinical practice guideline into a simplified care pathway. And I just want everybody to know that this is a 3-year plan. It's not going to happen tomorrow, but Ireland has got a central role in this particular work package, and this is exactly what we are working to with very, very strong cooperation with URDAs. So URDAs have a very central role in this pathway and with EPAGs and all patients. So watch the space. The Jardine kickoff meeting is on next week. Thank you.
Yeah. Thank you. Thank you. Thanks, and thank you so much. Thank you to the panel, to Cecily, to Ryan, to Gillian, and to Derek for your insight this morning. And I'm sure we'll have further discussions at now our slightly shorter, I believe, break. But it's always good to have those chats. We'll be back at, I think, 11:30, Vicky, for the next session. So thank you very much for your attention, everybody. Thanks. Thank you.
Hello to everybody. I'm going to call everybody back to their seats, please. I'm conscious that if we run over now, we'll run over later, and we'll all still be here at 7 o'clock this evening, and I don't think that's in anybody's interest, most importantly mine. The rest of you can stay until 7 if you'd like to. I'm on for that, but so if we can get everybody to take their seats. John, can you ask people to come in? Thank you. Everybody to your seats. Conversations can continue after the next session. Thank you very much. There will be a bit more of a break at the next session for lunch. So I would first of all just like to thank everybody involved in the previous session. Can I have some silence, please? Thank you. Everybody involved in the previous session, Avril for great chairing, and our 4 panellists, and including, of course, the 2 keynote speakers, Cecily and Ryan. I think that it gave us a flavour for, I guess, where policy is heading and what work needs to be done. Our next session then is, I guess, looking at tackling that thorny question. The first thing that arises in any patient's journey in the rare disease space is diagnosis. Getting to a definitive answer as to what is it? Why am I not well? Why is something going wrong? What is it? And this, as we've already mentioned, is a very thorny issue for lots of people. It is a very long journey, and it is, I guess, has been challenging even further in this country in terms of the support that maybe some of the basic services have had in the past, particularly the genetic services at Crumlin. What I would say is that the new national strategy, which is currently in implementation, is working towards a solution for all of us. You know, I guess it's a work in progress. So let's not hit people over the head on where we have issues or problems with this. So without further ado, I would like to invite Alan Finglas up. Alan Finglas is, again, known to many in the rare disease community. He's been shouting from the rooftops for many years. Alan's son, Dylan, has multiple sulfatate dystrophy and is sadly in hospital at the moment. So Alan has come from the hospital to be with us today. So a very special word of thanks to Alan for coming along. And I know Alan wants to make sure that, I guess, the conversations today are really about delivering for people living with rare diseases and their families, and so he feels that this is very important. Alan is also a research manager at MSD Action Foundation. About 2 weeks ago, Alan got a Patient Advocate Award of the Globe or the Universe or something over in the States. So Alan, you won't meet a more dedicated advocate for his family, for his son, and for the rare disease that has I guess affected his family to bring about research and things like that. So Alan, if you would like to come up, and thank you very much.
Thank you, Vicky. Good morning, everybody. So I would like to introduce our keynote speaker, which is Shirlene Badger, and she's the global lead of patient advocacy at Illumina. So Shirlene is the patient advocacy lead at EMEA at Illumina. In this role, she leads the patient advocacy strategy and engagement across the fields of rare and undiagnosed genetic disease, reproductive health, and oncology. Trained as a medical sociologist, she spent 15 years leading academic research initiatives at the University of Cambridge and elsewhere that sought to elevate the impact of the patient voice in the development and implementation of novel and experimental medical technologies. So, if you want to come to the stage now, Shirlene, thank you.
Thank you for that kind introduction, both Ellen and Vicky. I do want to say something first, though. Even though I live in the UK, it feels very important to me to say this. I'm actually a New Zealander. And this is very important right now because, as any good Pākehā white New Zealander, we have heritages that come from generally from this part of the world. And so I have strong Irish ancestry, which makes it all the more important for me being here today. As it was said in my introduction as well, I have come to industry in a rather, in no disrespect to my industry colleagues, but as a medical sociologist. If anyone knows what sociology is about, it's about looking at power imbalances. It's often about looking at the structures that exist within society and where and whose voice is being heard and whose voice is not being heard. And so I entered the field of rare disease a long, long time ago, at the point when if you were getting a diagnosis for rare disease, it was often because there was a clinician who had collected groups of families or people with similar phenotypes together and was hunting for the cause of that condition. And at that particular time, when BRCA1, BRCA2, and those genes were being announced, in my work as a sociologist, I was incredibly intrigued by what is the impact of understanding your condition to have a genetic cause on people, on families, on how they view their relationships, on how they make decisions about their life. And so that's how I came to the UK to do a PhD, one of the first PhDs really exploring the social aspects of receiving a genetic diagnosis. So I come with this background that is very much at the heart. An advocacy passion is about what is the voice of patients, what are the experiences, how do we make experience and translate experience into evidence that can be heard across structures and across decision-making situations. So Vicky's asked me to talk a little bit about the future. And one of the things that's really struck me as the 1 in 17 posts have been going through is how many people in those, when the words that are chosen next to them have hope or hopeful next to them. And I kind of want to start with a quote. It's a quote from a philosopher who says that life can only be understood backwards, but it must be lived forward. And I think there's a real sense of that in the rare disease community, that we need to, at this point in time, understand where we are in history, where we've come from, and where we're going. And so I'm going to talk a little bit about that in regards to diagnosis, what is happening in this space, where we're hoping to get to, and with a little bit of realism about where we are now. I can't start without highlighting, I guess, the very real experiences that people encounter in this space. And I'm very aware that in this room, I'm telling stories that you all live, and we have lived for many, many years. I want to introduce you to Charlie. Charlie is 15 in this photo. Her story is when I first met her family, they're from one of those villages where it's quite small, everyone knows everyone. Jodie and Terry, her parents, had grown up in the village, both of their families were in the village, and when they got together, there was much celebration. It was kind of one of those unions that, had been anticipated and hoped for. And when they got married, obviously from all accounts, it was a pretty big celebration. But then once they announced that they were having their first child, of course, all the family were involved. There was the great-grandparents were there, the grandparents were there, everyone was there. In fact, whenever I've been to their house, I've always encountered about three different grandparents, different aunties and uncles have all come in. So Charlie was born to much delight. There was, great anticipation around her birth and great delight. And everything seemed wonderful. She was born essentially meeting all newborn tests, looking healthy, looking great. About 6 months, and we'll be familiar with this story in terms of all our own experiences. About 6 months when, meeting developmental milestones, there seemed to be a few that just weren't happening. She wasn't sitting up, she wasn't able to move in some ways, seemed to be very late to coming to those milestones. In the family, there was still, again, she'll come to it in her own time, it'll be fine. And Jodie has a nursing background, and she was like, well, it'll be okay, she'll get there. And of course, the months ticked on, and still new milestones weren't being reached, or they were being very, very delayed. It was around 14 months, when Charlie was 14 months, that the assessment started. So Charlie had started moving about, sitting up at some point, but was struggling with, she did start walking, but there was a lot of delay. And so, as we know, investigations start. And there are tests, there are blood tests on very young children. There were all sorts of investigations, imaging tests, everything. At one point, one of the regular MRIs that they were having on a regular basis seemed to reveal something in a brain scan, and that was incredibly scary. They were rushed into hospital, but actually it didn't reveal the sinister diagnosis they thought was connected with it at that point. So it was back to the drawing board, and this continued for about 5 years in terms of every particular study that they could enter globally, they did. Hair follicles were sent around the world, lumbar punctures were done in order to try and investigate what's going on here. And the conclusion came that they didn't know what was happening. All they knew was that it was degenerative. When Charlie was about 5, Jodie and Terry tried to make a decision about were they going to have more children, what were they going to do? And they talked to a geneticist, they talked to a number of people, and they were told the chances of them having another child impacted by whatever it was that Charlie had were very, very slim. And so not long after that, Meg was born. And it was very apparent, very early perhaps, that Meg had the same symptoms as what Charlie did. And so, again, a whole other period of investigations occurred for both the girls. Although, as you see in this quote, Jodie talks about how Charlie was a bit of a guinea pig for both girls, went through endless testing to rule different things out. They tried everything. And this is really true. Little bits of the girls got sent all around the world in the pursuit of a diagnosis here. This is not just a blood test once in their lifetime. This is little bits of them being sent all around the world. They didn't know what it was, but obviously it was something regressive. Eventually, when Charlie was 10, a geneticist rang them and said, look, there's an opportunity here for a broader genetic test than what we've been able to do before. So obviously there'd been genetic tests in the past. There'd been a number of is this such and such syndrome? Is this, so a FISH analysis, is this such and such syndrome? And nothing had come back definitively. And the opportunity came for genomic sequencing, a broader scale genomic sequencing. And that resolved in a really interesting diagnosis. So they got a definitive answer after how many misdiagnoses. And this was the answer that essentially on the ADCK3 gene, there was a variation that was causing what was going on for both girls. Now, this is a cerebral ataxia. It affects movement. It explains all the reasons that the girls were not able to walk, that were the balance issues, also the cognitive issues. But the interesting thing about it is it affects the coenzyme Q10. Now, if I say CoQ10 to you, some of you might recognize what that is. If you go to a health food supplement, flaxseed, often it has CoQ10 as a supplement. So this is essentially a supplement that the girls could then be given, obviously at medical dose level rather than at the health food level that what we might have in terms of benefiting our health. And they wouldn't have known that. As Jodie says, we would not have known this without this result. So they were able to go on to medical dosages of CoQ10, and last time I was there, Meg was trying to skate in the kitchen. It was hair-raising but hilarious, and both girls, they're still a little bit wobbly, but they are able to walk, their quality of life is not degenerating in any way. So in this room, I know that we collectively know this experience. And there's this mystery around rare diseases. We don't know what they are, and we're still discovering what they are. There's questions about all the testing that occurs as we go to find an answer. And we have talked, as Vicky has said many times already today, about the long diagnostic odyssey that people endure in order to find an answer. And then, of course, that point where generally you're not as lucky as Charlie in terms of there are not necessarily therapeutic interventions that are clear. But the other thing that I do want to mention is that in the rare disease space, so today it's already been talked about 5,000 rare diseases, 6,000 rare diseases, 8,000 rare diseases. We've currently had a study come out suggesting that there are over 10,000 known rare diseases at the moment. We know that prevalence is not a fixed number at this point in time. And that's partly because of the growth of what we are doing in terms of understanding diagnosis. The methods for diagnosis previously, 10 years ago, didn't exist in the way that they exist today. So the other day I got a phone call from a mother saying, we've just got a diagnosis. Why didn't we get this diagnosis 10 years ago, Shirlene? And I said, well, to be honest, 10 years ago, we couldn't find this. There's no way we could find this because A, we didn't have the technology, and B, we didn't have the knowledge. And this is something that I kind of want to talk about and just keep resonant in your mind as we go through the rest of this presentation. So I just want to explain this. In the past, what I've talked a lot about, and this slide still kind of highlights the evolution of genetic disease testing. So I know that there are some conditions that do not have a genetic basis, but 80% of rare diseases, as we know of them now, do seem to have a genetic basis. And so what we've often done is there has been repeated genetic testing in people's experiences. And this has taken a number of different forms as the technology has developed. So when someone comes to me and says, oh, but I've had genetic testing done and it didn't show anything, often we get down to they might have had a single gene test because it was assumed that it was Angelman syndrome. They might have had a FISH analysis done, which is a particular closed view of a particular number of genes. They might have had karyotype testing, which looks at the chromosomes and can't necessarily reveal everything. Or they might have had phenotypic panels. So phenotypic panels, some of you will be familiar with these. If symptoms look like they're epilepsy symptoms, there are epilepsy panels. These don't, again, incorporate all the genes, but they look at a select few and a select few variants that are linked with certain phenotypes. As it says there, there's often around 200 genes in that panel. We have multi-phenotype panels, so these are larger panels that start to look at 700 to possibly up to 7,000 genes. And then as we've moved on, we've started looking at a broader spectrum in terms of the human genome. And in this, we've started to see people employing whole exome, and this has been much more successful. So this looks at the coding areas within a person's genome, so those areas that code for particular behaviours. And then we've seen SNV and CNV, and more importantly, as we've kind of continued, we've started to see progress into the whole genome. And one of the people that I hold in high regard as my kind of North Star, he talks about, Shirlene, if we look at the whole genome and we're hunting for something, it's better than taking just a chunk of the haystack and hoping that you've got the needle in that chunk that you've taken off. If we've got the whole haystack, we've got a better chance of finding that needle. Obviously, it's still a needle in a haystack, but we've got a better chance of finding it. What I want to suggest in this, so while this is described as an evolution, and this is a timeline in some ways, it's also perhaps useful to think about it in terms of resolution. So that, by that I mean our actual view. And I often, when I'm sitting here going like this as I'm talking, but I often think about those people that I used to observe in the lab who were literally looking down the microscope, trying to count off the chromosomes before their tea break, and then coming back and trying to count, that you've got to count them so many times. So it's about the actual limitations of the actual view that you're getting on the whole system, on the healthcare system, on the body, and on the genome. So what we're seeing is that as this increases, we're coming to know a whole lot more about rare diseases. We're coming to be able to define them with a little bit more accuracy. So we're coming to be able to give definitive causes for conditions in a way that we haven't been able to before. And as we're doing that, this is changing the landscape rather dramatically. It's changing the landscape both in terms of prevalence, like I've talked about. It's also changing how we start to interpret rare diseases, what they're called, what their impact is, all those sorts of things. But we're also understanding that genomic variation within humans is diverse. We don't know, most of what we know at the moment is based on a European male reference system, and we need to increase that diversity, increase the data in which it's going. But as we're doing that, we're recognizing that people often don't just have one variation that is causing their condition. It's becoming more common to also have 2 variations, 3 variations that perhaps are the cause of their condition. So there's just been a study published actually just this week that I want to talk about in terms of the value of this and the value of expanding how are we looking? How are we actually decreasing that diagnostic odyssey? How are we giving an answer earlier? Could whole genome potentially be an answer for a first-tier test? And what do we need to do to get there? So in what conditions is it looking like it can be an answer as a first-tier test, meaning that all that other testing can go out the window and we can just start with something that might provide us with a definitive answer. We've still got a long way to go in terms of this evidence. But as I said, there's been a study that's been just published just this week. It's drawn on data from the Rady Institute in the US, from the Hospital for Sick Children in Toronto, from Genomics England, from a number of other studies. It's over 70 studies have been incorporated into this review, with obviously tens of thousands of patients being included. And in this study, they've just announced 5 recommendations in which we should be arguing for whole genome as a first-tier test to end the diagnostic odyssey, to reduce that time to accuracy of diagnosis. And one of those is as a first-time test, particularly for pediatric patients or for new infants who end up in a NICU, so a neonatal intensive care or an intensive care. And that's obviously with unexplained symptoms, so this is in the cases where it's not clear, it's not an accidental cause as to why someone is in intensive care. But the diagnosis rate in those contexts is proving to be really, really high and incredibly valuable. And we have an example in the UK, actually, at Exeter, where they have a really rapid turnaround system. So this is another issue. We've always thought that whole genome takes years to do or months to do. Actually, Exeter has managed to introduce it with a turnaround time that is appropriate for those neonatal intensive care units and give an answer really rapidly. The other recommendation is that whole genome be recommended when sequential tests are being considered because it's not clear of the results. So most of us know that in our rare disease journeys, there have been sequential tests. There has been a test for a particular syndrome, there has been a panel, there has been maybe then exome and maybe then genome. I know many families for whom the first sample was Angelman syndrome, then the second was whole exome, and it might have revealed a variant, and then you need to test it against the parents, and that parent has that variant as well. Now we need to do whole genome before you get an answer. So if that's the case, they're recommending that actually what we should be doing is whole genome as a first-tier test. The third point was instead of panel testing, especially when it is known that not all the variants are collected within that are connected with that phenotype are within the panel. That's perhaps a much more challenging recommendation. I was quite surprised to see that, but I think it's an important point. And they also said that when patients are being treated for a non-genetic condition, but have a clinical course or response to therapy that may be better explained through exploring whole genome sequencing. So value has been seen in projects across Europe. Some of you will be aware of other projects that are implementing whole genome. So for example, after much work by the patient organisation AXA and by Christine Monlos, there's been kind of a lot of work. This has been almost 10 years in the making. The German government has now decreed that all rare disease patients will have whole genome as a first-tier test, and that's about to be launched in April. It's a pilot project, it's called the Model Project, and it will run for 5 years and check the data and see, is this something that we're going to implement? But we see moves happening across different European countries, across the US, and obviously in the UK as well, where this has been explored in terms of the value. Now, Vicky also asked me to talk a little bit about AI and data. Now, obviously, whole genome raises a whole lot of questions about data. It produces just an enormous amount of data, and what do we do with that? And we've also heard today about the carrying of hospital records. So I know mothers particularly seem to bear a disproportional responsibility for collating the evidence around their child's condition and carrying it from specialist to specialist. I've seen folders that are honestly this thick or require one of those trolleys to take in to each different clinician that they go to. So what does this mean in terms of data, and how are we going to explore this? And I think there are some answers coming in electronic health records that we're seeing implemented in different countries that are starting to help that process and streamline that process. But also, I want to say that we need to do this as the interpretation of what this data is telling us. So whole genome sequencing is obviously complicated in terms of the data that comes from it. And the more that we learn, the more variants that we find, the more we're going to uncover variants that are called variants of unknown significance, where we haven't seen them before, we don't know what they are. How do we collate that data then? If we haven't seen what they are and we do a quick search on scientific papers to see if anyone else has reported them, and someone hasn't reported them because it's a variant of unknown significance, how do we actually start to find and collate those variants of unknown significance that might actually be pathogenic when we collate that data? So there's a lot of AI technology going into developing this, into thinking about how do we build networks where we think about this data, we bring it together. We know this in the rare disease space. We know that by virtue of being rare, we need to find each other, and we need to build collaboration, and we need to share data. It's not without its issues, but this is of extreme value, particularly in the rare disease space, and particularly actually as we grow in prevalence, as we grow in the understanding of conditions, and how maybe it's going to be more useful to group certain gene conditions together under certain umbrellas rather than them being known as the old school syndrome names that they have been known of in the past. Alongside this, there's AI technology that's being developed to help lead towards the diagnosis, to help build the value case. So a lot of us will be aware of some of the facial phenotyping work, particularly that is significant in low middle income countries. So I think of Gareth Bainham and his work in Aboriginal Australians, and that when you can't get people out there, how do you take effective imagery that might actually help to lead to evidence for doing further testing to explain the condition. Again, all of these systems require data, and they require a sharing of data, and this is the big issue that we still have to overcome. We're working hard on it with the European Health Data Space, but this is something that we're still thinking about very carefully. The other project that I do just want to flag up while I'm talking about AI, some of you will know Julian Ayla, who is a patient advocate based in Spain. He has a son with a rare disease. He has a background in Microsoft, and he has developed an incredible technology that is using language systems to read all the clinical notes that people are collating, and to then basically pinpoint a selection of, or a hub of possible scenarios. And we know that we know that, well, I know that we all do this anyhow. People say don't go to Google, but everyone starts Googling in their search to try and find a diagnosis. And this is like a more systematic kind of approach of how do we use Google, how can we use the language that we're seeing, you know, how do we type in the exact symptoms that are going to raise the profile of what we're looking at. So there's a number of incredible initiatives going on. And how they all join up yet is yet to be seen, but I think there's enormous potential there. And I have to say, as a sociologist, I've often been scared about the whole data issue. So me even saying this is a huge, huge step. So, you know, we're getting there. We're all getting there in terms of what's needed to improve the space. I just wanted to touch on newborn screening as well before we conclude. So one of the things that I want to talk about really is I think it's probably best to reference a study that again has just been published at the end of last year. This is a review of what is occurring in the newborn screening space. It's a review then that occurred looking at newborn screening projects that were happening across Europe that were utilising NGS technology, so next generation sequencing technology. And what the authors did was they admit that this might not be exhaustive because a lot of these projects are research-based, but they looked across Europe to see and to survey then the leads, the healthcare professional leads of these projects, and to kind of identify what they were looking at, how they were utilising it, and what were their views. So you can see there on the slide, there's an image of the initiatives that they were able to identify. So there's Baby Screen, there's Screen for Care. Some of you will have heard of Screen for Care is the multinational one, so that is reflected twice, really, in terms of Germany and Italy. And I think it's also going to have a site in Greece. And what I did like about this study, so it's something that I've put the reference there, and you can go away and have a look at it. This is all research-based at the moment, so it's seen as sitting alongside the current newborn screening initiatives. But what is happening in the patient advocacy space is as we're identifying more and more rare diseases, and as we're changing, I guess, the measures by which we talk about utility, so that is, in the past, we've always talked about clinical utility as being measured by, is there a treatment? In the patient advocacy space, we're saying, actually, we need to talk about what is actionable. When is something actionable? And actionability is much more diverse than just treatment. Treatment is diverse in itself, but it can be about reproductive decision-making. It can be about food choice. It can be about a whole lot of different things. It can be about, in osteogenesis imperfecta, it can be about handling a baby in a way and knowing that you're not breaking its bones and not the cause of the condition that they are then ending up in hospital for again and again and again. So is that actionability? So this is a huge swing that we're seeing in terms of how we're thinking about these conditions, and as we're identifying more conditions and as we're reducing the diagnostic odyssey, we're seeing the potential for development of therapies change. Therefore, this is going to change how we do newborn screening. And the test system that we have, the biochemistry test system that we have, may not be fit for purpose in the future. So there's this idea, if we look at genomes, are we able to select, like with treatments, that we're going to, like with panels, that we're going to look for these genes, we're going to look for these conditions, and what would that look like? What would public acceptability of that look like? And one of the great things that they did in this review as well was explore with each of these studies who they were engaging with in terms of their stakeholders. And some of these studies, so the French study particularly has had a really remarkable project that has started very much with both the patients, rare disease patients, and then with public and citizens about acceptability and moving that forward before they even got to the point of looking at ethical approval for continuing. Those studies are proving to be really, really important. And I think that's something that we need to remember. And it's talked about this morning, is that even the difference in the current plan is that we're including patient voice right at the beginning and embedding it within that. And I think we need to do this also, not only with patients, but at a citizenry level. And I know Ireland has a great history of doing this really, really well. The other thing that's interesting about who they've been including is other professional societies, but also making sure that they're including those decision makers on newborn screening panels in this whole process as well. Because the view is not that this is going to automatically roll out into and be adopted and implemented. It may be that it sits alongside our newborn screening projects for a while, or programs for a while. But one of the things that they did say, so one of the respondents believes that NGS-based sequencing will replace biochemical pretty much very soon. However, with all of them being research-driven, a lot are saying that it's going to take a little bit more time. But interestingly, all of these people said that in the next 10 to 15 years, they think this will be adopted as a first-tier test, as a mechanism for newborn screening. So I guess to conclude, really, I just wanted to talk about how, as we're seeing changes in this whole landscape, in this ecosystem that are being so elegantly led by the patient advocates who are bringing multiple stakeholders to the same table, like today, to discuss issues that cross so many different systems, we're seeing change happening in this space. And the result is that in providing accuracy of diagnosis, we're better able to change the landscape in terms of treatments. We're better able to do the research that leads to successful treatments. That means that children are not being experimented on because we don't necessarily know what's wrong, and so they're being given certain treatments that may actually be causing more harm than good. This is coupled with the technological advances that we're seeing, so especially in genomic sequencing, and particularly again in the reduction of that turnaround time. So being able to produce a result back to bioinformatics to interpret within a very short space of time. And then we're starting to see the advances that we need in computational and artificial intelligence advances, which help with that interpretation. And I think as this system evolves hand in hand, all together, as these advances are happening, we're seeing quite a transformation, what I think is quite a potential transformation in the rare disease space. So in terms of the quote that I started with, we started with that life can only be understood backwards, but it must be lived forward. And what I want to just remind you of is that we're talking about a particular time in history at the moment. We are talking about advances that we're coming to know about, that we don't know about fully, but they are changing that space. That once upon a time, this is what was happening. So it used to be that, a rare disease diagnosis was taking, on average, 12 years. One mother said to me that it took 18 years for them to get their diagnosis. And once they got their diagnosis, that was the end for them. That was the end of their diagnostic odyssey. But what we're starting to see with this accuracy now is that, yes, this answer is an ending to a diagnostic odyssey. It's being shortened, but it's an entry point. So this accuracy becomes an entry point to our national plans. It becomes the entry point from which we can facilitate future research. It becomes an entry point by which we start to develop our understandings and develop the ecosystem, recognizing the broad range of stakeholders that need to be involved. It doesn't end with diagnosis, we all know that. The battles that continue post that are immense and often very varied, but it is the starting point. And Avril said right at the beginning that society is judged by how it treats unmet need. And I think this is a crux for us at the moment. This is a real crux in terms of how do we move this forward? How do we recognize the potential? How do we see the change that this can bring for the real life experience of families, of children particularly, and change this whole landscape for where rare disease sits, how it's understood, and how it's interpreted. So there's been a lot of references to the Rare 2030 Foresight Study, to the EU plan, to the national plans. But I really want to stand alongside the IRDIC promise too, so the International Rare Disease Research Community promise, and Eurodis, who are saying that they imagine a future, we all imagine a future in which people can come to a diagnosis within a year of coming to medical attention. And that's, at times that can feel like a scary goal, but actually I think it's an achievable goal. It's an ambitious goal, but it's something in terms of things are there. We've just got to join up these systems now and start to work out what does this look like, how can we implement it, and where is the work that we need to do. That's all from me. Thank you very much.
Thank you, Shirlene. If you'd like to take a seat at the top table. And at this point, we'll invite the panel up, please. We have Nuala Ryan. She's the Chair and Board of Trustees of NCBRS Worldwide Foundation. We have Richard Hagan, who's the Interim National Clinical Laboratory Director. He's also from the National Genetics and Genomics Office, and the Chief Medical Scientist Laboratory Co-Director of the Irish Blood Transfusion Service. And we've also got Abigail Collins, the National Clinical Lead of Child Health and Public Health. So, Shirlene, we might just start with you. So, one question first. You mentioned the neonatal units in Exeter.
Yeah.
I was particularly interested in how rapidly can they turn around whole genome sequencing. I suppose essentially how, and have they got a machine on site?
So yes, Exeter do have a machine on site. So the turnaround time there for the actual sequencing, so I do just want to make sure that we're aware of so there's library prep that needs to occur on the sample prior to it having sequencing, but sequencing can occur within 24 hours. And then there's the interpretation. So I'm not sure of the exact turnaround time. Johnny, do you know? I think it's around 48 hours or something like that they're getting results back. Obviously, we might think that that's not necessarily fast enough just yet, but it's incredible progress, and 2 days for a result within the NICU is really amazing. So Exeter is doing that. We also, I was going to just mention, and I didn't mention it in my talk, but there's another example that I think is rather exemplary, and I know we often get annoyed, if I dare say this, that the cancer space seems to, be able to sort pathways out. But this is in pediatric cancer, pediatric cancers are considered very rare cancers. And one of the most extraordinary moments for me in the last couple of years has been visiting Princess Maxima Hospital in the Netherlands, and I'm not sure if people are aware of it. So if you are diagnosed with pediatric cancer in the Netherlands, all pediatric cancer cases go to Princess Maxima. And if you go to Princess Maxima, it's one of those settings that is purpose-built to not only give answers, but to facilitate appropriate personalised treatments. So it is set up, the wards are beautiful, there's like hospital wards, there's even a band room, like it's pretty cool, like there's a lot of cool stuff there. But then suddenly, there's this big glass wall, and you go behind that, and it is the biggest hive of activity that you've ever seen. So the sequences are there, everything, every piece of kit that you might imagine that is needed to give answers to children. There are lab technicians, there are bioinformaticians, they all are working there. So that the data goes backwards and forwards within the same building. It goes through those glass walls and comes back. So the development of therapies then is happening on a really personalised level, is being tested on site, moving to the child, going back. It is one of the most remarkable examples, I think, of what can be achieved in this space.
Okay, thank you. A question to Nuala Ryan. Thinking about the importance of diagnosis, how has having a diagnosis helped your family, and is there anything that you think you might have done differently had you known earlier?
All right, so my child has a syndrome called NCBRS. We found out when he was 12 that he had this diagnosis. But immediately having that diagnosis meant that I could go out there, start researching. I mean, when I was told the diagnosis, I was told, well, there's no treatment for it, so it wouldn't really have made a difference. But, you know, from a personal point of view, it made a huge difference because immediately we were able to know what to expect in the future, you know, how the syndrome develops with age, you know, some of the symptoms, you know, how best to manage them, what interventions worked, proactive planning, because we could see that, you know, there was issues with sight. So some of the kids in their 20s had gone blind because of glaucoma or by cataracts, and because the children couldn't communicate, they couldn't say that. But, you know, you can then be proactive and have those tests done. It's easily to test for those if you know that that's a possibility. But it also helped me as a parent to be more proactive. And now we've set up the foundation. We're able to, even though it may not help Charlie, I have another Charlie, we can help make those treatments available in the future and feel like you're making a difference and doing something, which I think is important as a parent. In terms of what I would have done, what would have been different had I known, I think some of those proactive things. I mean, Charlie ended up in ICU, you know, with status epilepticus. Epilepsy is kind of a common thing with the syndrome, but we didn't know that. So we would have been able to do that. It would have avoided some of the tests that he did have. He has short stature as part of the syndrome, so all those growth hormone tests and stimulation and all that. So I think we would have also, now Charlie's lucky in that he can speak. He didn't speak till he was 5 or 6. But I think, again, we were told, look, he probably will never speak, but I think had we known and seen the kind of spectrum of children with that, we could have got earlier intervention. We would have had that power to say, I think a diagnosis opens up more doors to get certain interventions, knowing that that is something that's associated with, so yeah.
Thank you. Question to Richard. So leveraging scientific advances, terms such as whole genome sequencing, metabolomics, proteomics, and artificial intelligence are becoming increasingly commonly used. So how near or far do you think we are from embracing some of this and maybe even leapfrogging today's technology?
Yeah, I'd just like to say, Shirlene, your talk was fantastic. Spoke to a lot of what we're looking at for the National Genetic and Genomics Office, which is recently established. That leapfrogging piece is exactly a conversation with Shirlene earlier, just as to, you know, what is that in 5 years' time? What should we be looking at? What should we be looking to implement in terms of our technologies and capabilities? So building from the ground up pretty much is where we're working from in this country, or where most of our samples will be sent away to the UK and labs in Europe. For the sequencing, we have no public service capability within the country for whole exome or whole genome sequencing at the moment. So in terms of building capacity and capability, you know, do we start out by going straight to whole genome sequencing? Is that where we should be looking at? Again, reference to other pieces, the methylation proteomics and transcriptomics and so on. Those are all pieces that we have to take on board in terms to build a service for this country. And obviously there are a lot of challenges from infrastructure, IT, AI, workforce planning, governance and funding. All of those pieces we're working together with offices, National Rare Disease Office, Eileen, obviously we've been working closely with NCCP, NWIP and so on. And so we're aware of the challenges, but definitely in terms of very much looking to what that future place will look like and how we deliver those services, we'd definitely very much look to leapfrog into that space.
Thank you. So a question for Abigail. When we talk about newborn screening, we all think about the heel prick test, but of course there are many other tests and screening activities too. What should we be thinking about? You know, is there anything outside of the box we should be thinking about as well? Possibly facial recognition. You know, what's your opinion on other possibilities?
Yeah, and I think, you know, technology is showing us there are endless possibilities for how we look at things. You know, sometimes things come down to sort of how you define what you want to achieve and what is associated with those definitions. So from my perspective, we have the Universal Programme of Clinical Care for all children, and that's a universal programme. A lot of those bits are called screening, but in terms of real population screening programmes in the end-to-end way, we have the newborn blood spot screening programme, which many of you know as the sort of the Guthrie test, the heel prick test, and we have the hearing screening programme, and they are, they're fantastic programmes in terms of that we can look and we can kind of see end-to-end what's happening, and it's easier to sort of see your gaps and your spaces and where you can go. Even within those pieces, there is the context of where do we go with technology, where is the sort of functional response that we get from the blood spot screening programme that is of real value and a fairly quick turnaround time to our clinicians, blend with the sort of, the molecular information that sometimes can take a while. We can get the answer before we know what the answer means sometimes. We can get a genetic answer, but we don't quite know what that's going to mean for the patient in terms of their clinical day-to-day activity. So I think there's going to be, our engagement is going to be important, and I think there's always going to be that overlap between sort of functional and molecular in this kind of short term. And then I suppose for me there is this kind of broader piece for children, and I think you had a really nice phrase when you in your presentation, which was lovely. I agree with Richard when you say, what does public acceptability look like? And I think that is really key, which is slightly different from this kind of screening or pseudo screening or checks or surveillance side to there's something not quite right with my child that I'm worried about. So as a parent, when you have a concern with a child, what you are happy to do in a kind of clinical perspective is slightly different. We know it's slightly different from what our parent who has a child that they don't consider has any clinical concerns are prepared to do. And that's always the kind of challenge and the balance. And I suppose lots of countries have come up with solutions like the Screening Advisory Committee, which are really tasked with that kind of looking at that blend of we want to get the throughput to where we need to get to support children and families, but we have to respect, we have to respect the sort of the parent space as well as the patient space. So that's always really an interesting challenge, and I think the advent of technologies will accelerate those conversations, and I think it's really important we have them. And you're right, we do have a really nice kind of history in Ireland of having those kind of tricky public conversations, and I think this is one that would be nice to see touching on that engagement more, and I think that will help us in our sort of strategic way forward.
Okay, thank you.
Pick up on that a little bit?
Yeah, and then we'll open up to the floor for questions.
So, I think what you've said is a really important point, and I didn't bring it out of my conversation, but it is quite different. In the rare disease space, we've known this long search. There's clearly been something that needs an answer. And that is quite different when we're talking about the application of sequencing at a population screening level. Avril mentioned earlier the Rare Barometer survey. I think that's really informative, actually, because we've just done 2 surveys, one on diagnosis and one on newborn screening. And the results of that will be published, I think, around May. But the results of that are quite striking in terms of public acceptability, and I think that's why these projects around public acceptability are important. But the other thing I didn't mention, what I think has been really useful in the research projects around newborn sequencing, is that they're also incorporated, many of them have incorporated studies about how do you get a good genome, so how do you get a sample. And I do want to just kind of dispel the myth too that this replaces the blood spot test, because actually what we've seen, and I think in each of those studies at the moment, is that if we can get good enough genomes from the blood spot, that's obviously the way we still want to go through. So this is not a kind of let's replace the blood spot and get rid of, and then, are we going to bleed babies, to get a genome? No, I do just want to make sure and clarify on that point.
Yeah, and I think that's right. I think that's important, and that would be part of that public acceptability.
Exactly.
And operational feasibility is one thing to do a heel prick. It's another thing to take a venous sample from every baby in the country, for example. But I think there's something else as well. There will probably likely be an overlap period in terms of technologies because of that functional information. So do you have the chemical or not, and therefore can we start the treatment, which genetic information may not tell you that, because you can have a sort of a spectrum that we're not quite sure. Some very classical types you might know, that's fine, we need to get on and give this medicine or this treatment or this pathway. But sometimes clinicians are left not quite sure, you know, and that's always going to be a challenging space. And I suppose the one thing that the more conventional sort of tandem mass spec and methodologies that are used in the blood spot screening program, for example, give you that functional information actually in a tight turnaround time still currently. So I don't think it's going to be a case of throwing the baby out with the bathwater. No. I think it's going to be a case of actually these things are evolving, and we need to involve in tandem with technologies for clinical output and in tandem with patient and public acceptability. And I think those are conversations we need to have together.
Thank you. Just in the interest of time, we'll take a few questions from the floor, but if there's any longer questions or really burning things, we might save them just for the break. So, yeah, go ahead, Mary.
I have a short question and a comment. I just wanted to tell the panel about a mother who came to me. She qualified for genome testing. She had her paediatric neurologist in a major teaching hospital in Dublin do the genome testing. She didn't get the proper diagnosis. He was stuffing it down her neck that the child had cerebral palsy. So she had to go privately. She was just determined to get an answer, spend the €10,000. The genome testing was repeated and the clinician gave the required clinical information and she got an answer. So that's what's happening on the ground.
Yeah.
And just earlier we had somebody from PSP say about doctors should really push the patient organisations, and I think he's right, but sometimes the patients don't want to go to the patient organisations, and I just think that's something we need to think about. And I found myself, even though I had medical qualifications and all the rest, it was my non-medical husband pushed me and said, go on to the patient organisation and see what they have. But certainly a paediatric neurologist with an expertise in this, saying it's cystic fibrosis or a cerebral palsy and nothing else, and you know.
To bring back to Nuala, I know in your world and in the conversation that we had before today, I'm really interested in actionable versus treatable. What does that really mean? What's really happening there? Because I know Shirley referred to it as well, and I think it's, you know, it brings, I guess it goes to the back of the ranch, as Anne Lawler might discuss.
So I'm actually working on a project as well, Screen for Care, that you referred to earlier, and you know, part of that is newborn screening, and really they are looking at that, kind of trying to standardise across Europe for newborn screening, and they're really qualifying it based on an actionable panel and a treatable panel. So treatable, I think, is the kind of what we're seeing more now. It's, you know, is there a treatment available, you know, whether it be a drug or a gene therapy or a diet supplement, let's say for PKU or something like that. But actionable is much broader and much more relevant in terms of what I would kind of see. So, you know, it could be looking at interventions, that proactive health management and social, like, which will help the overall quality of life and social kind of integration of a patient, making sure that, you know, looking at the health management plan, looking at and I think it goes beyond the patient as well, because it's really looking at the family, the caregiver, it's looking at all that reproductive planning, you know, that whole infrastructure around the patient. So that's why I think the actionable is much more important. I think with both of them, you know, when you're looking at what needs to be taken into account, of course, you're looking at what's the severity, you know, of that, what's going to happen. Is it, you know, prevalence? There's all kinds of criteria that you could have to look at for those actionable panels or treatable panels. But I think it is really important that we are looking at beyond that treat and making it a much more broader categorization. Yeah.
Vicky, you actually, I think, kind of read my mind. That's exactly what I was kind of going to ask. In my community, in the retinal degeneration community, we've done a landscape study across Europe, and it is going back to this issue of, we talk about what happens when you get the test. It's such a challenge to actually get access to the test, because it's 5 years, 5 different clinical consultations to be referred in the absence of treatment. And that's the challenge, because you can take action in the absence of treatment. And I think it's a mindset that we need to shift as society to that genetic testing is specific, it's niche, it's much, much more than that. And advances, as you've referred to, demonstrate that. But we need to understand that. I know we've genes and genomic strategies being developed currently, but we must go away from that. And just as a patient representative in the retina space, I was told once, Avril, patients don't need genetic testing. And my answer is, we don't need to need it. Yeah. You know, we have to have it, particularly for complex genetic disorders. So I suppose it's a mindset that we all have to change. And back to your point as well, Mary, it's that education at primary care level as well, that's really, really important as to, you know, and also we must understand as well that patients get access to genetic testing from a research perspective, and they're not aware of the fact that there is no obligation to provide a diagnosis when you're involved in a research program, and you know, these are the things that we just as a society need to understand better.
I just want to pass a comment and just listening very carefully there. And there's huge potential, obviously, in the genomic method, but my worry, I've been a long-term advocate for expansion of our newborn screening program here in Ireland for years now. And it's built momentum slowly, very slowly, but it is progressing, and I would hope to see it progress in the coming years. My worry would be that, and you've mentioned it and addressed it, but I'd like to reiterate it, that this is not a replacement or a substitute for the development of our existing program, which lags way behind international standards and needs improvement and rapid improvement in parallel, and I would say prioritization to the development of our traditional method in parallel to the overall development of this, you know, much more long-term project in an Irish context, given our limitations. But yeah, I want to just bring the focus back to the day, to, you know, today. Yeah. And I say that on behalf of the parents of the children that will be born next week and the week after and the week after, every week in Ireland now, that require screening for conditions that is available in other countries but not available here. So we're failing those parents and those patients currently, and we need to get up to speed. It's not that we have to make huge advances in an international context, we just have to catch up with what others are doing. You know, somebody said a measure of our society is how we meet unmet needs, but I would go further and say the measure of the society is a measure of an adult human, is how they look after the infants, you know, our newborn babies. It's our most basic instincts. And I've been saying this for years, as I said, but that's my true belief, is that as a society we're failing our most vulnerable citizens, and as parents and adults we're failing our children on that front. I don't want to leave it on that negative note. We're not failing, we're advancing, and there's promising progress in the field, but I did want to bring it back. What we're dealing with today.
I just want to say thank you for, I know that I touched on that, but I think we're very aware of the disparities across Europe in terms of newborn screening programs. I mean, it's enormous, and there's several studies that can map that out, and we've got a long way to go, and that should be happening now, that some conditions are,
Okay. Could I make one final point, Vicky? Very quickly. Just, I mean, I think in terms, you mentioned about the exome and the whole genome, I mean, I think it's important to note that sometimes it'll come up with a variant that may consider, like for Charlie, 10 years before he's actually diagnosed, we knew that this was the variant that was probably his issue. But because it sits in a paper file, there's no one able to go back and relook at that. So I'm just thinking, in terms of the diagnostic journey, you need to have the data infrastructure to have that information in the database, whether it be using AI then for any new conditions that are recognised, I suppose, after that initial gene test is done, that it links up the pieces and that people get a diagnosis as quickly as possible as that new information comes available, because it's too manual at the moment to make it an easy process. That's all I wanted to say.
Just before we conclude, one very quick question to Shirlene. Myself and Les Martin are working with a researcher in the US who actually received the Guthrie Award in recent years. And he's classifying all 6,000 variants, potential variants of MLD, and also he's working with a group in Germany for my son's condition, and they're classifying all 6,000 variants for MSD. When you think about, a diagnosis, getting the whole genome sequencing, you get the readout and you might have variants of unknown significance, or you might have 2 variants of unknown significance. We're creating basically a encyclopedia which will be there for all time, so that if there is a treatment, then you might think, well, is this patient going to respond to that treatment? Are we sure this is actually these are pathogenic variants? For me, this is the future. And yes, this is subsequent after we get a potential diagnosis. What do you think? Do you think that something like this is a good business model for a company like Illumina, or do you think this is we can't have 10,000 research projects trying to do this for 10,000 rare diseases when you take in different genetic variants and whatnot within individual diseases? Do you think this is something for the future?
I think this is definitely a project for the future. In fact, I've got something that I'm developing at the moment just around VUSs, because as you've said, they can sit there and there's no system at the moment for going back to those VUSs unless you know that that VUS has even been reported to you. So often VUSs aren't reported back in any way, shape or form. So patients don't have access to that data to then be able to fight on that. But also in certain systems, after 3 years, you're able to get the lab to re-examine it in some countries. But people don't know that, and if they don't know that they've got a VUS, they don't know that they can get that reassessed. So the issue is that at the moment we don't have a system that is growing with the knowledge in real time. And I think this is where, I touched on AI as being a mechanism by which we can start to do that. I think we need new systems that talk between ClinVar and all those programs that are being utilised for assessing pathogenicity of variants, but we don't have systems that are doing that talking to enable quicker reassessment. So I think this is an enormous issue going forward. I think it's an important issue. I don't have a business proposal, but
I think we need somebody to take this on, because for me that's the future. And it really makes a lot of people's job easier as well. Okay, thanks very much, ladies and gents. We'll go to lunch now, and if there's any questions for the panel,